So I'm going to talk a lot about lung health today. And in order to do that, I just wanted to show a quick picture of what the lungs look like. So here are the lungs. You can see the lobes. You can see the diaphragm up under there. You can see the heart tucked in behind the lung lobes. You can see some lymph nodes. You can also see how the lungs branch out into those air sacs. Those are the healthy air sacs that you see there in that picture. So everybody take a nice, big, deep breath. Inhale, and now we're exhaling. And our healthy lungs are doing their job for us today. So in 1964, the US Surgeon General, or what's called the nation's doctor, released the very first report about the health effects of cigarette smoking. This report included the review of over 7,000 articles. It concluded that smoking causes lung and laryngeal cancers in men. It probably caused lung cancer in women and was a cause of chronic bronchitis. The report concluded cigarette smoking is a health hazard of sufficient importance to warrant remedial action. And for those of you that might have questions about who the US Surgeon General is, well, this person oversees the US Public Health Service Commission Corps with the goal of protecting, promoting, and advancing the health of our nation. So the 50th anniversary report, which was published in 2014, detailed additional lists of consequences from health smoking. Smoking is linked to diseases in nearly every organ in the body and is the leading cause of preventable death. The economic costs of smoking are estimated at about $300 billion annually, which includes roughly $150 billion in productivity losses and $170 billion in direct medical care. In one of our previous talks, viewers learned more about tobacco products, and they did see information about these toxins in cigarettes, but the information does bear repeating. Since we know that there are about 7,000 compounds and chemicals in cigarettes, we like to show this graphic up to healthcare providers and also our clients or patients because sometimes they don't realize the things that are inside cigarettes. So I might say, you know, that stuff that you use to take off your nail polish, that acetone, well, that's inside of a cigarette. So sometimes this is a really good teaching tool that we use with the tobacco users to help them think about quitting smoking. We get a lot of information and questions about e-cigarette use. So I do put this up here and I provide a reference, a source for you down at the bottom as a footer to this article about health risks and safety of electronic cigarettes. We know that health cigs likely pose less direct health hazards to individual smokers compared to tobacco cigarettes and might help smokers quit smoking or reduce harm by smoking fewer cigarettes. Although toxicants have been identified in e-cigarette vapors, the levels of these toxicants are orders of magnitude lower than those found in cigarette smoke. So although it cannot be said that currently marketed e-cigarettes are safe, e-cig vapor is likely to be much less toxic than cigarette smoke. There's an awful lot of research being done right now to really better understand the health consequences of vaping and e-cig use. So for now, this is the story that we're telling about e-cigarettes. So in 1965, around the time when that very first Surgeon General's report was released, about 43% of Americans smoked. In 2018, about 14% of Americans smoked. So today, about 38 million adults and about 1.1 middle and high school students are smokers. Cigarette use causes almost all of the tobacco-related disease and death, contributing to 8 of the top 10 causes of death. And smokers have a 50% chance of dying from their smoking habit. More than 16 million people have at least one smoking-related disease. The overall smoking rate among adults in 2017 in New Jersey was 17.1%. And we also know that smoking rates are a little bit higher in the southern region of the state compared to the northern region. And this graphic here shows you the breakdown of smoking rates by race ethnicity for the period 2011 to 2018. This chart shows the use of different tobacco products for males and females in 2017 in the whole United States. As you can see from the chart, about 25% of males used any tobacco products compared to 14% of females. And you can see that cigarettes were the most used tobacco product overall. And then you can see there the differences between males and females for the other tobacco products as well. We realize e-cigarettes are not on this list at the time. And so we will be tracking and looking at all this tobacco product use into the 2018 and beyond shortly. So this graphic shows all of the cancers and chronic diseases that have been linked to smoking. You can see that smoking can damage nearly every part of the body. This includes parts that we don't always associate with breathing in smoke, like from the mouth down into the lungs. So things like the eyes, where smoking is a cause of blindness, cataracts, and macular degeneration. It also can affect things like rheumatoid arthritis and ectopic pregnancy. So sometimes when you're working with your patients or clients, knowing that what their medical history is, the personal health history, you can actually talk with them about the things that they're dealing with personally and why their tobacco use might be making those health issues worse. There are many cardiovascular effects and consequences of cigarette smoking. For example, there is an increase in circulating epinephrine, likely caused from surges in nicotine levels, increased heart rate, increased blood pressure, vasoconstriction of coronary arteries, increased atherosclerosis, and increased platelet stickiness. So these things also smoking can also cause early hardening of the abdominal aorta, which supplies the blood to the abdomen, pelvis, and legs. And this hardening can lead to aneurysms, which is a weakening or bulging of an area. So the danger is that the aneurysm can rupture, leading to life-threatening or fatal bleeding. So in fact, any organ that gets a blood supply can be affected by tobacco smoke. And it's important to note that nicotine is not the major contributor to CAD. So we'll do poll question number 2 now. What % of current smokers believed they had a higher than average risk of heart attack? 10%, 30%, 60%, or 90%? What % of current smokers believed they had a higher than average risk of heart attack? 10%, 30%, 60%, or 95? Oh, the poll says 95 or 90 or 95. we can close out that poll. Okay, so about half of you said 30%. All right, we're going to talk about pulmonary diseases first. So there are also pulmonary effects, including increased mucus production, decreased ciliary clearance function, suppression of the cough reflex, increased airway hyperreactivity, migration of immune cells to airways, and so on. So all of these adverse effects are also not related to nicotine. And we want to point out that emphysema, chronic bronchitis, and asthma have all been linked to tobacco use. Also, that smoking increases the risk for infection in folks that have any and all of these diseases. Here is a pictorial representation of what happens to those air sacs I showed you earlier when someone has emphysema. You can think about the alveoli being like a bunch of grapes, and the surface of each grape is where the oxygen comes into the blood and the carbon dioxide goes out. With emphysema, that surface area is compromised, making the lungs far less efficient and unable to do their job. As you can see here and from the picture I showed earlier, there are many other health consequences of tobacco use. So things like diabetes, impotence, infertility, osteoporosis, and rheumatoid arthritis. Smoking can also increase the risk of birth defects and have surgical complication-like effects on anesthesia and wound healing as well. There are about 7 million deaths per year due to smoking worldwide. And there are about 480 deaths in the United States every year that are due to smoking. This is about 1 in 5 deaths per year that can be attributed to cigarette use. Smoking contributes to more deaths per year than HIV, illegal drug use, alcohol use, motor vehicle accidents and injuries, and firearm-related incidents combined in the United States. This pie chart provides a breakdown of the 480,000 deaths in the United States every year that are attributed to cigarette smoking. You can see about a third of the deaths are heart disease, close to a third are lung cancer deaths, about a fifth, 20% or so, are COPD, and then there are other causes of death in there as well. So this gets back to the other poll question. We know that consumers are underestimating their risk. A study of current smokers found only 29% believed they had a higher than average risk of heart attack, and only about 40% believed their risk of cancer was higher than average. Further, among heavy smokers, so those are the 2-pack a day or more smokers, only 39% acknowledged a higher than average risk of heart attack, and only about a half acknowledged a higher than average risk of cancer. Let's do poll question number 3. What percent of lung cancers are due to smoking? Blank percent of lung cancers are due to smoking: 10, 30, 60, 80 to 90, or 100%. What percent of lung cancers are due to smoking? Okay, we can go ahead and close that poll. All right, 80 to 90% was written by 71% of you. It's pretty good. That is the answer. This is an illustration of normal cells. They're on the right, and then dividing, right, by apoptosis, they would die, and that's the normal process for cells. When things go awry and things start being abnormal and the cells start dividing, then a tumor will start to form. So smokers are 25 times more likely to develop lung cancer compared to non-smokers. Smoking causes about 87% of all lung cancers in the United States. And smokers today are at greater risk of developing lung cancers. We think that is due to cigarette design changes. So for example, filters and vent holes, which may lead a smoker to pull that smoke in deeper with each inhalation. And there's also been some changing chemical composition of cigarettes over time, which also would contribute to the greater likelihood of developing lung cancers. You can see over here on the right, the relative risk for lung cancer. The risk of developing lung cancer among non-smokers is very small and stable over time. You can see that's the gold bar, non-smokers. The risk for male smokers has increased over time, and the risk for female smokers has outpaced their male counterparts. So you can see how the darker shaded gray bar has increased dramatically when you look at 1982 to 1988 compared to 2000 and 2010. This may be due to the fact that historically more males smoked compared to females, and then marketing campaigns helped to drive up the smoking rates among females. While cigarette smoking does cause the majority of lung cancer cases, there are other risks, and here we list out some of those other risks. Exposure to radon, exposure to secondhand smoke, exposure to other substances, including those in the workplace, such as asbestos and arsenic, family history of lung cancer, and then there are other causes and risks that are currently under investigation. So radon exposure, which is the second leading cause of lung cancer, causes about 20,000 lung cancer deaths each year. Radon is a gas that occurs naturally in the ground, and it gets trapped in houses and buildings. It cannot be seen or smelled, and it's estimated that about 1 out of 15 homes may have high radon levels. Homeowners can test their homes themselves, or they can hire certified radon measurement companies to come out and test to see if their home contains higher levels of radon and if they are unknowingly putting themselves at risk and need a mitigation. We're going to go with poll question number 4 now. True or false? Lung cancer is the leading cause of cancer death for women in the United States. True or false? Lung cancer is the leading cause of cancer death for women in the United States. We can close out that poll. 69% of you said true. So in the United States, 234,000 people are diagnosed with lung cancer annually, and this accounts for about 25% of all cancer diagnoses each year. And lung cancer is the leading cause of cancer death in the United States, with about 154,000 Americans dying from lung cancer each year. Lung cancer death accounts for about 27% of all cancer deaths each year. And here we give a little bit more New Jersey specific information. The rate of new cancer diagnoses overall is slightly higher in New Jersey compared to the rates across the entire United States. In New Jersey, among both females and males, lung cancer is the second most common type of cancer diagnosed each year. For females, it's second to breast cancer diagnoses, and for males, it is second to prostate cancer diagnoses. The New Jersey Cancer Registry released a report detailing new diagnosed invasive lung cancers. This graphic on the right shows age-adjusted incidence rates per 100,000 people. New cases of lung cancer are higher among males compared to females, and the counties in the darker shade of red, so down in the south, they show much higher rates for both males and females compared to the counties in the lighter shades of red and pink toward the north part of the state. Many times when I give this talk, we ask the audience to tell us about what cancers they think cause the most cancer death for females and males. And usually we hear breast cancer for women. Well, according to the New Jersey Cancer Registry data, lung and bronchus cancers are the most common type of cancer death for both females and males in New Jersey. So remember that poll question, the lung cancer is the leading cause of cancer death for men and for women in New Jersey. The overall survival rate for lung cancer in New Jersey is 17.7%. As you can see in this graphic, the 5-year survival rate is about 50% if the cancer is found at stage 1, when the cancer is small and hasn't moved outside of its small contained area within a lung lobe. The more invasive the cancer, and so looking further along on this graphic, the worse the 5-year survival rate is. So you can see their stage 4, it's only 1% survival, 5-year survival rate. Most people with lung cancer don't have symptoms until the cancer is advanced. And just, sometimes people just don't feel well. And then they have some of these symptoms that are listed here: coughing that gets worse or doesn't go away, chest pain, shortness of breath, wheezing, they might be coughing up blood, feeling very tired all the time, or have a weight loss with no known cause. So unfortunately, lung cancer symptoms appear late. This means the cancers are detected at a later stage when treatments are much more likely to not be effective in curing that cancer. This pie chart shows information from 2009 to 2015. It shows the percent of lung cancer cases by stage of diagnosis. So you can see the greatest proportion of cases were found after the cancer had moved outside of the lungs into the regional lymph nodes and beyond. only 16% of lung cancers were found when they were still confined within the lungs. So what the goal is with screening, right, is to try to improve the number of cancers that are found at that early localized stage. So how do we find them when they're localized and treatable? Well, it's prevention, and in this case, it's secondary prevention. It's screening, which is used to identify diseases in the earliest stage before the onset of symptoms. Well, how do we do that? How do we do lung cancer screening? Well, there were studies that were done. The largest one to date is called the National Lung Cancer Screening Trial. It was co-sponsored by the National Cancer Institute and the American College of Radiology. It was initiated in 2002, and the primary results were published in 2011. It's the largest study of lung cancer screening to date. And it was a multi-center randomized controlled study of LDCT versus chest X-ray. The study enrolled over 53,000 high-risk individuals, and you can see the eligibility criteria for study inclusion listed here on the right-hand side of the screen. So what did this trial tell us? Well, it told us a bunch of benefits, and I list some here. The LDCT group demonstrated a 20% lung cancer mortality reduction compared to the chest X-ray group. Well, what does this mean? Well, the LDCT group had 17.6 deaths per 1,000 over the 7-year study period, while the chest X-ray group had 20.7 deaths per 1,000 over the 7-year study period. Less people died in the LDCT group. There are some risks to LDCT, so we point them out here. These came out of the trial. There is a risk of radiation exposure with each scan that's done. One person may be exposed to 1.4 MSVs of radiation, which is a little less than a low back X-ray and certainly less than a diagnostic chest X-ray or PET-CT. There is approximately 1 cancer death attributed to radiation by imaging per 2,500 screened subjects. However, the risk associated with radiation are unlikely to manifest for decades after the exposure. So it's just important to mention that they might be having a scan today, and it's going to take years and years before that risk actually presents itself as a cancer or a cancer-related death. Another risk is what's called false positives. Benign nodules can be found, and these are called false alarms. The nodules subject individuals to unnecessary testing. So what do these numbers say? So of 1,000 screened individuals, 356 will have a false positive. Of those 356, 18 will have an invasive procedure. And of those 18, 1 will have a major complication such as bleeding in the lung, collapsed lung, or infection. And just to go back to what I was saying before, to sort of compare, for annual breast mammography, the false positive rates are between 50 and 61% over the 10 years of screening. Another risk associated with LDCT is overdiagnosis. So this simply means that screening may find cancers that would never have caused symptoms or harm in the patient's lifetime. The trial data showed that about 18% of the cancers that were detected would have remained undetected and would not have led to a lung cancer death. Many times when we give this talk, we have providers asking us about numbers needed to screen to prevent cancer death. And so we created this slide. It's a comparison of the 5 currently recommended screenings for lung, breast, colon, prostate, and cervix. And so you can see here for LDCT, you need to screen 320 patients to prevent 1 cancer death. And you can compare that to mammography, where it's completing 726 mammograms to prevent 1 cancer death. We're going to go into poll question number 5 now. True or false? Only current smokers are eligible for lung cancer screening. Only current smokers are eligible for lung cancer screening, true or false? We can close that poll. 81% said false. So based on that trial I just mentioned and other trials, the United States Preventive Services Task Force, the USPSTF, recommended annual lung cancer screening as a grade B recommendation on December 31st, 2013. And here are the eligibility criteria for LDCT. It is recommended for individuals aged 55 to 80 years old who are current smokers or former smokers that quit within the past 15 years. They should be heavy smokers that have at least a 30-pack year history. So what I mean by that is somebody could be a 1-pack-a-day smoker for 30 years or a 2-pack-a-day smoker for 15 years. These folks should not have any signs or symptoms of lung cancer and have not previously had a lung cancer. And USPSTF does not recommend screening for individuals that are not willing to have surgery for lung cancer or for those that have a condition that greatly limits how long they will live. They also recommend annual screenings until the person is no longer eligible, that they no longer meet the eligibility criteria. Sometimes we have people ask us a little bit more about USPSTF. So I did a couple of screen grabs here for you to see. This is the website. I give you the source down at the bottom, so you can go ahead and Google them or use that website to find the USPSTF. And you can see here that I do pop this out so you can see the recommendation. It's a little bit bigger there on the right-hand side of your screen. If you also look a little bit closer, you can see there's some PDFs with supporting documents, and there's some other information in there for providers and consumers as well. So, feel free to go around there and hunt around for more information about lung cancer screening. And sometimes we have people say, okay, well, I see that big giant green B there. It's not an A, it's a B. So what does that mean? Is it good? Is it just a guideline? Is this definitely a go? Should we do this? So I provide here some additional information about what this grading really means. So USPSTF recommends preventive care services for patients based on evidence of the benefits and the harms of the service. And they assign these letter grades, A, B, C, D, and I, when they're recommending the routine delivery of a service to patients. So you can see here by their definitions, a grade B recommendation, such as LDCT, is definitely a go. USPSTF recommends this service to be provided. LDCT is the only recommended lung cancer screening test for lung cancer screening right now. Not chest X-ray, LDCT is the only recommended screening. I showed this picture here. This is a picture of a former smoker and a lung cancer survivor. She is part of the campaign from American Lung Association called Saved by the Scan. And I include this picture because sometimes folks out there have never even seen the equipment that is used for these LDCTs. So you can imagine you have a patient, they lay on that table and they just roll through that donut shape for the pictures to be taken of their lungs. Okay, so we know we have this scan. The number needed to scan number is pretty low. We know that it's a good, there's benefits, there are some risks, but that we certainly want to get people screened. So let's think about utilization. Are people out there actually getting their LDCTs as they should? Well, according to the National Health Interview Survey in 2010, only 3.3% of eligible individuals received their LDCT scan. And in 2015, unfortunately, only 3.9%. So 5 years later, it only went up to 3.9% of the 6.8 million eligible individuals received an LDCT scan. Further, according to the BRIFIS, in 2017, when they dropped a module into BRIFIS for 10 states, of which New Jersey wasn't one, unfortunately, 12.7% of adults aged 55 to 80 years that met the USPSTF criteria for lung cancer screening. And among them, only 12.5 or 1 in 8 reported they had ever received an LDCT scan in the past 12 months. So this risk factors surveillance system identified 12.7% of adults in that age group that were eligible, and only 1 in 8 were reporting having that scan done every year or in the last 12 months. So further about utilization, again, folks they ask us, well, how does this compare to other screenings that are recommended? So again, here I list out the 5: cervical, breast, colorectal, prostate, lung. I list out the screening tests, the eligibility criteria, and then the utilization numbers. So you can see we're doing all right for cervical and breast. There's work to be done for all of them. But then if you see down there all the way at the bottom in bright red with an arrow, about 5.9% of adults aged 55 to 80 who are at risk and eligible for lung cancer screening had an LDCT scan. I realize that number is a little bit different from the previous slide. This is based on another study. This is based on 2018 data, but still less than 6% of those eligible actually receiving the scan means that we have an awful lot of work to do to get more people in the scans. So what might be one of the barriers to getting individuals into the scan? Perhaps provider knowledge. So that is indeed one issue that we see in the literature. So we know that healthcare providers are unfamiliar with lung cancer screening guidelines. There were a couple studies done, so I put some information up here on the slide about this. There was a study done in Seattle with PCPs and pulmonologists, and about half of them reported needing more information about the eligibility criteria for lung cancer screening. And about 69% were able to correctly determine screening eligibility for at least 3 of 4 patient scenarios. So there's work to be done to try to give them information about eligibility criteria and then for them to actually apply the criteria to patients to understand if that patient is actually eligible. And then in a study done in LA among PCPs, about half knew that LDCT was the recommended screen by the USPSTF. So here you see that there is work to be done to educate healthcare providers about LDCT as the lung cancer screening that is recommended by USPSTF. Many times when we give these talks, folks ask us questions about insurance coverage as a barrier to lung cancer screening. Under the Affordable Care Act, annual lung cancer screening with LDCT is free to eligible insured patients with no out-of-pocket expenses, so they shouldn't have any deductibles or copays. We know that private insurers, Medicaid and Medicare, do cover LDCT screenings. Also, there are resources in New Jersey to pay for screenings for eligible individuals that are uninsured or underinsured, and I'll talk about that a little more later. LDCT does require a written order from a physician, and the patient must participate in the shared decision-making SDM visit with the doctor to discuss the benefits and risks associated with screening. Many times we also have folks in the audience ask us about the codes that should be used on those orders. So we provide this slide as well. Here's some coding that can be used. And also I provide the diagnostic codes down here as well. We do have some lung cancer screening sites tell us that if the diagnostic codes are not written in there correctly, insurance will not cover the scan correctly. So let's talk briefly about shared decision-making. SDM is a communication and counseling process in which a healthcare provider discusses options and works collaboratively with patients toward the patient's preference-based decisions. It means the patient is the one making the decision about actually getting the lung cancer screening after that patient listens to and talks with their doctor about the risks and benefits of the scan. And we know that insurance providers like Medicaid and Medicare require the use of one or more decision aids to be used in that SDM process. So what do I mean by decision aid? Well, the picture here on the right is a snip of the graphic from the Agency for Healthcare Research and Quality. And so I provide the source down there at the bottom of the slide as well for you. So you can go to that website and you can pull those decision aid tools, and then you can just use them with your patients and clients to walk them through the SDM process. So you don't have to remember all these details. They're right there on the pieces of paper for you to talk through with your patients and clients. Importantly, in the shared decision-making process around lung cancer screening, there should be things that are talked about, and I list them here. LDCT is the only recommended screening approach for lung cancer. We certainly want to make sure we're talking about the harms and benefits of screening, including the possibility of follow-up diagnostic testing, the risk of overdiagnosis, false positive rates, and radiation exposure. In this process, we want to talk with our patients and clients about the importance of adhering to annual lung screenings while they're eligible, and how the patient and client should be willing to undergo diagnosis and required follow-up if necessary, and especially the ability to undergo treatment for cancer if that's what's identified. Importantly, and in bold here, with any patient or client we speak with in the shared decision-making process, we want to take some time to talk about the importance of tobacco cessation among current smokers and remaining abstinent among former smokers. There is evidence that tobacco users at lung cancer screening are highly motivated to quit. Intense, comprehensive tobacco treatment is often needed for this population, since this high-risk group is probably likely highly dependent on nicotine. So we also know that many contacts with different clinicians can reinforce the need to quit using tobacco products, and those encounters can be brief. They can be 2 A's and an R, and they can then lead this patient or client into more intensive tobacco treatment, say at the quit centers we have here in New Jersey. Tobacco treatment should be offered to all tobacco users, even those that are not exactly immediately ready to quit. And there are techniques to help move those types of folks through the stages of change to try to get them to become ready to set a quit date, let's say. This graphic here is from the MMWR that I mentioned earlier. It's a nice infographic and a nice way to show patients, clients, providers, healthcare professionals some of the very important key takeaway messages of today's talk and of lung cancer screening in general. We know that lung cancer is the #1 cause of cancer death. You can see here, this is what the machine looks like. And we know that screening with LDCT can detect lung cancer early and save lives. We know that more screening is needed. We know about 7 of 8 adults who met the criteria did not report receiving their screening. And we provide here on the right-hand side, you can see the eligibility criteria for lung cancer screening. And again, for those of you that want a little more information about heavy smoking history, that is the 30-pack year history. So that would be smoked 1 pack a day for 30 years or 2 packs a day for 15 years. We want to make sure that we talk with our patients and clients about how quitting smoking greatly reduces the risk of lung cancer and other health consequences of smoking. You can see here in the graphic to the right what happens over time when a person quits smoking. So within 20 minutes of their last cigarette, heart rate and blood pressure drops to a more normal level. You can see within 12 hours, carbon monoxide levels start to return back to normal, and so on, climbing up this mountain. So that by 10 years post-quit date, the risk of dying from lung cancer is about half of a smoker's risk. We want to make sure to tell our patients and clients that quitting smoking is the single most important thing a smoker can do for their health, including reducing their risk of lung cancer. It's never too late to quit smoking, and there are resources available throughout New Jersey to help tobacco users quit. This slide lists out the quit services we have here in New Jersey. I invite everybody on the line to visit tobaccofreenewjersey.com because we list out a lot of resources and information there on that website for all of you. One thing that's listed there on that website are our New Jersey Department of Health funded New Jersey quit centers. The tobacco treatment specialists at those quit centers provide free individual and group counseling sessions, and they're across 12 counties. Right now they are virtual, providing one-on-one over Zoom or other virtual teleconferencing capabilities or over the phone. And the group sessions are also being done over video conferencing as well, which opens up the opportunity for these quit centers to see people that might live outside of their county catchment area. Also, what's great about the quit centers is if you are working with patients and clients who really need a lot of contact time with counselors, these counselors are trained to do a 45 to 60 minute new patient assessment. So that's just 45 minutes to an hour strictly talking about a client or patient's tobacco use history and their desire to quit and the things that would need to go into a treatment plan for quitting, a quitting plan. So there's a lot of time to devote to just this one topic area where we know a lot of healthcare professionals just don't have that much time. What's important about this as well is that the treatment specialists at these quit centers have information and materials about lung cancer screening to give to their eligible clients. They are able to figure out if the patients and clients they see are eligible for lung cancer screening and give them this information so they can make some decisions about going back to their provider to get a written order for a lung cancer screening. We also have Moms Quit Connection for Families and Quit for Kids. I'll give you that website and phone number here as well. This is free individual telephone or face-to-face counseling to families with children under the age of 7. They also have a texting program. So I invite you to take a look at that website and use the contact me option there on that website if you're looking for more information about this service. And finally, on this list, we have our New Jersey Quit Line, 1-866-NJ-STOPS. There's also a wonderful website. I was on it yesterday. It's wonderful because a patient or client can go to that website first and get some information. They can find the phone number and call the phone number to talk directly with a quit coach to do the registration process, or a tobacco user could actually register themselves using the website, and then a quit coach will call them back. So this is a free telephone-based counseling service for New Jersey residents 18 years and older. So all of these things that are listed here on this slide are free of service, so free of charge. So insurance will not be billed for these services. Also importantly, the quit centers and quit line are giving out free NRTs right now. So that is a major barrier for some of the tobacco users. They don't have the money on hand to buy these products to help them to quit smoking. So the quit centers and quit line can offer some free NRTs to help these clients out. I want to take just a moment to talk about ScreenNJ. You've seen the logo at the top of my slides through the whole talk. ScreenNJ is a collaborative project of organizations throughout the state committed to reducing cancer incidence and mortality. Right now, our initial focus is on colorectal and lung cancers, but we are hoping to expand. ScreenNJ promotes the benefits of tobacco cessation and lung cancer screening for eligible New Jerseyans. So we have this beautiful network of community organizations such as religious orgs, food banks, and schools. And the list of this network of organizations that are partnering with us continues to grow. And we love that that's happening. And so if any of the organizations out there on the line would like to talk more with me about hosting educational sessions on any relevant topics for the community or for providers, we're happy to have those conversations and try to host something together. We do increase education and knowledge on the most up-to-date research for lung cancer screening, and tobacco mitigation for healthcare providers and the community. And ScreenNJ is able to provide grants to community partners to increase lung cancer screening, including providing grants to cover the cost of LDCT for patients that do not have health coverage. I provide here our screennj.org website, and especially drill down into that website to show you on the right, there's a button that can be clicked called Click Here to find a lung cancer screening facility. So if you're out there and you're a healthcare provider or a community organization, and let's say you're in Cape May County, you can click on that button and type in your zip code, and then it should spit out for you all of the lung cancer screening sites that are in your catchment area, so that you will know the lung cancer screening sites that your doctors or your providers could then send their patients with their written order for their lung cancer screening. Also here, I do want to acknowledge some of our ScreenNJ lung cancer screening partners. This is our list of lung cancer screening partners from fiscal year 20. We will be expanding this list to include our fiscal year 21 partners shortly. For now, here is our list. So these partners have grant money to be able to offer free LDCTs to uninsured individuals. So you want to make sure to, see if your clients or patients have that as a barrier, and then you can call the phone number to get more information about how to make that referral for your clients or patients to get their LDCT scan done. At this point, I'm going to go ahead and I'm going to stop my talk. I'm going to leave this slide up though, in case all of you hadn't had a chance to really look that over and write down some notes. And I'm also going to tell you that we are recording this talk, so we will be posting a video of the talk, and we will also be sharing out the slides to the registrants as well. So those will be coming via email, hopefully within the next couple of weeks. So with that, I'm going to turn it over to Nicolette, I think, who's looking at that chat.
Thank you so much, Heather, and great job. So we've had a few questions come in. The first, any ideas on why smoking is higher in Southern New Jersey? Is it a function of income or cultural practice?
That is a great question. I think I might need to take a sip of my coffee to help me answer that one. No, you're absolutely right. So there's lots of different reasons for why the rates are lower, or I'm sorry, higher in that portion of the state. Yes, it's related to the folks that live there and their preferences. Yes.
Thank you. The next question, why is the survival rate less in the 2A group compared to the 2B group? This was, I think, related to earlier in your talk.
I think this is related to the slide about the different, let me see, the survival slide where we go from stage 1 all the way to, so I cannot answer that question exactly. I pulled this graphic from the New Jersey Cancer Registry. So what we can do is get one of our oncologists or other researchers that question, and we'll include that answer when we do our Q&A document.
And everyone, please feel free to continue typing in any questions you have. There was just one more to please share resources for screening uninsured. But as you can see, this slide provides some good information on that.
Right. And so if anybody out there is thinking about maybe wanting to become a partner to receive some grant money to be able to offer those free LDCTs or to do other sorts of outreach around lung cancer screening, please send me an email and I will forward your email to Emily, who is our program manager, who can get you more information about writing up those grant applications.
Additionally, please make sure you take a moment just to fill out today's evaluation. I included the link in the chat box.
Great, Heather, thank you so much for this wonderful and super informative talk. This was just chock full of great information that we can definitely apply to our everyday practice. I know 4 weeks has gone by literally in the blink of an eye. So next week is our very final session of Be in the Know. So be sure to join us for the final week. We have a really great presentation on tobacco cessation for the LGBTQ community, a tongue twister, right? So definitely be sure to join us. My colleague Dominique Noel will be presenting. She is our team expert on LGBTQ health. She is just a wealth of knowledge, so we're really excited to have her join. So feel free, this weekend you'll receive the links again to all 3 sessions for next week's topic. So we'd love to have you pop into any or all of the sessions, and we look forward to seeing you. And before you exit out today, we love to get your feedback. So just be sure to fill out the evaluation, and we're always happy to craft and implement and deliver sessions on topics that you would like to see. So thank you so much, everyone, for joining us. We appreciate your dedication of time today, and we look forward to seeing you soon.
Thank you. So I'm going to wrap it up now. I had to talk very quickly. Thank you all for hanging in there with me while we worked out our technological problems earlier this morning. At this point, let's open it up. I've been seeing things pop in the chat box all during this talk. So Daniel, if you're out there, tell me something.
I am out here somewhere. So we have a ton of questions. The chat was really active. A lot of great questions.
I'm excited.
I know we're kind of limited on time, so I've one of the discussions that's been going on in the chat is regarding the criteria for LDCT, both at facilities or for patients. So if you could just, touch on the criteria that facilities have to meet in order to perform LDCTs.
Okay, so, and I'm gonna turn my video on and hopefully y'all can see me, and I'm gonna pull that chat box up as well because it's always interesting for me to see that. So just so I have a better understanding, So is it what the facilities internally things that they need to do, or the actual eligibility criteria for somebody?
It looks like a combination of both. We've had questions on both sides.
Okay, great. So, so right now, what we know is we understand there are different eligibility criteria out there in the universe, right? But we are promoting the USPSTF eligibility criteria because those are the criteria that the insurance companies are working with. So your clients, if they're not 55 years of age yet, if they're, let's say, 45, they may have trouble getting insurance coverage, but you can certainly help them through that process of trying to get their coverage. A lot of times you have to do pre-auths and other things like that. So the eligibility criteria are kind of rigid right now around the health insurance part. We understand that there are people out there that might have health risks and other things happening in their lives that they might say, well, look, I'm exposed to secondhand smoke or something like that. That's an individual thing for healthcare providers to work through with their patients and clients and try to get that pre-auth done through the insurance companies. And in terms of internal to organizations, one thing I do want to talk about, since I have a minute or two, that I wasn't able to describe on the talk today, we know that it's really difficult internally to figure out if a patient or client is actually eligible. The hardest piece of the criteria is pack year history, right? So you can figure out if they're a current or former smoker, you can figure out their age, but can you figure out how many pack years they've got? It's hard. So sometimes what's useful is within your health system, if you can develop an algorithm sort of in your EMR where you can put some information in and it sort of does the calculation behind the scene, and then it spits out to you, oh, this person is eligible for lung cancer screening because they met the criteria, that will help you. So we've done that actually here at Robert Wood Johnson Medical School. We have this algorithm built in, and it is helping the providers to be able to see if somebody is eligible and then go ahead and do shared decision making and write the order for the lung cancer screening. I hope that helped. If others on the line, and since we are running out of time, if folks have questions and I haven't quite answered, please email me. What we're going to do is put all of the questions in the chat box into a document, and I will go through them with our medical director, answer your questions, and we'll get those answers out to everybody. So even if I don't get to your question during the next few minutes we have together, we will answer it and you will get your answers hopefully within a week.
Great. So, all right, another question we have, and I'm going to kind of combine two of them we got, since they're pretty similar in regards to, you know, specific guidelines being created or adapted. So, one person had asked, in minority populations, some of the LDCT guidelines may have to be revisited since their exposures to menthol inhalation for preferred brands create higher nicotine exposure at earlier ages. And then also, someone had asked if there will eventually be screening protocols or guidelines for secondhand smoke exposure.
Excellent questions. And I don't know if y'all can hear in the background, my dog is barking because he's so pleased to hear both of these questions. So you're right out there. Thank you for bringing up both of those issues. We know that these guidelines right now are what they are. They're a bit rigid. They're based on certain studies. And my understanding is that these guidelines are currently under review and may be expanded. You're absolutely right. We know that there are groups of people, because of the type of cigarettes they smoke, menthol is a great example, that they may not meet the pack year history because they're maybe not smoking as many cigarettes per day, but they're indeed pulling in maybe even more toxins than somebody who's a pack a day smoker. So we need to keep our eyes and ears open to how these eligibility criteria may change. We'll keep our eyes and ears open for research studies that are coming out. They're being done right now. And so hopefully over time, we'll be able to expand these criteria out for certain populations. It is certainly an issue. And so again, if you have clients or patients that have certain personal health histories and are worried about certain things, then you can certainly try to work with them and their insurance companies to get a pre-auth for a scan. And especially if somebody starts presenting with certain symptoms, that's a new ballgame. And then as a medical professional, you have to start to evaluate what the symptoms are they're experiencing and what your next steps might be with that client or patient on an individual level.
Awesome. That was a great answer. Thank you.
Thanks.
And again, these will be answered following the presentation as well. So in a little more thorough manner. So, you know, feel free to keep shooting questions off in the box. I'm writing them all down. So we have a couple more minutes left. Here is another question. I thought you would like this one, Heather.
Oh no.
Let me get to it.
I do see one while you're looking. Let me just answer really quick. One,
Yeah.
I see it says, who completes the shared decision making in the lung screening program? Who completes shared decision making? So that's a really good question. So you have to think about, you need to do shared decision making for insurance coverage to happen. So it really depends on who's going to be billing for what services. So in fact, the radiology departments, because they're the ones doing LDCT, they will do shared decision making with the client when the client walks in the door. But you can also be doing it sort of from the primary care perspective as well, right? You want to make sure you're talking with the client and patient so they understand what they're getting into before you write the order for them to get the LDCT. In my opinion, shared decision making doesn't take that long, and it's really important to build rapport with these clients and patients because they're going to be coming back year after year to get their scans. So it's important to have these conversations with them where they feel comfortable with the process. I see one other person out there saying these slides are pretty great. Can you please share? Absolutely. I think Michelle will be talking about the sharing of materials in a couple more minutes. All right, Dan.
All right, quick hit, one more. So is there a possibility that screening rates are low because doctors don't know the screening eligibility guidelines?
Oh my gosh, if my dog could bark again, he would. That is a fabulous question. Yes, in fact, we know, I didn't put this slide up there today, but we do know that physicians and healthcare professionals don't know this scan exists, or they know sort of in theory it exists, but it's just not in the forefront of their brains when they're working with their clients or patients. So one of the things that we can do is to make it a little bit easier for healthcare professionals. And that easier thing would be building in an algorithm into the EMR, building in prompts. How do we make sure we sort of hit this one while we're going through vital signs, let's say, right? And the way to do it is to build in the PAC year history question, because then you have the 3 parts of eligibility criteria. So part of what we're doing today is trying to increase healthcare provider and professional knowledge around lung cancer screening. So if anybody out there has any ideas about how we help inform our healthcare providers, maybe through grand rounds, other tumor board talks or something where we can come out and do these talks to the healthcare providers, please send me an email because we'd be happy to come out and do more of these talks with all of you. All right, Dan, hit me. You got, it's 11 o'clock.
It's 11 o'clock. You want one more?
Give me one more. Let's do it.
Okay, one more. This is all right. This is a cool question I found in the beginning of the presentation related to radon. Is radon testing mandatory when selling or buying a property?
Oh my, that's a great question. So I actually would need to check into that. I know that there are certain testings that need to get done. If I were going to be a new homeowner in New Jersey, I would certainly request a radon test be done. There are resources on the New Jersey website that we can make that available, and we'll put that out there in our shared documents that Michelle is going to be talking about. So Dan, please make a note of that, and we'll make sure we post that up with our shared documents.
Gotcha.
Awesome.
All right.
Great. Well, thank you so much, Heather and Dan. This was a really phenomenal presentation. So if you haven't had a chance to fill out today's evaluation, we would love your feedback. You can just click on that bit.ly link in our chat box. We always are developing new programs, so we'd like to get your thoughts, your feedback, your perceptions. And please, please join us for our final week of Be in the Know, which, believe it or not, is next week. We have our final session on tobacco cessation for the LGBTQ+ population. And everyone should have received an email. We normally send them out at the very beginning of each week with all of the open Zoom links so you can join. So we'll keep doing that. But if you did notice in the link that you received this morning, there was all of the recorded videos for week 1, and we'll also be sending out week 2 and week 3 shortly this week. So we look forward to seeing everyone again next week. And from our team here at Rutgers Cancer Institute of New Jersey, ScreenNJ, and the Rutgers Medical School, we thank you so much for your dedication of time, and we wish you a really great week ahead. Be well, everybody.
Thank you, Michelle and Dan. Goodbye, everybody. So at this time, I'm going to just say thank you. We're running out of time, and I want to make sure we open the floor for at least a couple questions. So at this time, Michelle, I'm going to hand it over to you. And I'm going to try to see the chat box as well.
Perfect. Thank you so much, Heather, for this wonderful presentation. Unfortunately, we don't have any questions right now in the chat box, but if you do, please feel free to enter them. We'd love to address any questions that you have. And we've also placed our evaluation link in the chat box as well. We always love your feedback. And as we grow and develop our programming around lung cancer screening and tobacco cessation, we love your input on where you would like to professionally develop, and we can customize a training session for you. So it looks like we have one message. Oh, I love this one actually. This is from Kathy, and she's asking, what is third-hand smoke?
That's a great question. Okay, so we know that secondhand smoke would be somebody smokes a cigarette and they're right beside you and you breathe it right in. Third-hand smoke would be the residual stuff that's left over. So let's say someone's a smoker and you might notice their windows or their carpet looks a little yellow. That's from the junk that was in the cigarette smoke. So that's the third-hand smoke exposure. So we think about that, especially when we think about young kids who are on the floor, right? Babies who might be on the floor on that carpet where some of that junk landed. That's third-hand smoke. Good question.
Great. Yeah, that was a wonderful question. And we have another one that is asking, are there any programs that are specific for college students when it comes to smoking cessation, this is another awesome question.
It is an awesome question. And that will actually tie into, surprised we haven't gotten an e-cig vaping question as well. So yes, there are services in New Jersey available to this population and younger as well. If you go to the New Jersey Prevention Network, there's a way there to go through their network and find some of the services. That website I gave you for the Quit Centers, Healthy New Jersey website, that Tobacco-Free New Jersey, I'm sorry. That website will also link you up with services for people of younger ages as well and college age students. Mm-hmm.
Great. And then I know we have an important question on the ballot this year for New Jersey, which is medical marijuana. So this is one of the questions that we have is in terms of what the research is on smoking medical cannabis. And then there are other consumption and topical solutions, but it's on the ballot this year. So something definitely to consider.
Yeah, that's great. You're right. And, you know, as healthcare professionals in this field, we have to keep our eyes and ears open to all of these issues as they're popping on ballots and in other places. So right now, there is research being done. It's very difficult right now to tease out the health effects of marijuana smoking because many times those folks are also tobacco users as well, right? So they're smoking cigarettes and smoking marijuana. So there are studies out there, we can look toward them, but right now it's very difficult to know that or link marijuana smoking with lung cancer. That's not there yet.
Great, thanks so much for your response, Heather. And it doesn't seem like we have any additional questions. We'll definitely give it another minute or so. And in the meantime, we would invite everyone to join us for our 5th and final week of the Be in the Know series, which is a really exciting topic area and is tobacco cessation for the LGBTQ+ community. This session will be provided by one of our community cancer control specialists here at the Rutgers Cancer Institute, one of our very own Dominique Noel, who is our expert resident in LGBTQ+ health. So we really are looking forward to hearing from her next week on tobacco cessation support and services available for the LGBTQ+ community, as well as the health disparities that do go along with that. So we thank everyone so much for your time and joining us today. Thank you so much for dedicating your lunch hour to us. We had a great turnout and we look forward to seeing everyone next week. We'll be sending out the link with the recording for week 2. So if you miss week 2, don't worry, you can still watch the recording, as well as some additional supplemental resources. So we'll resend all of our Zoom links as we normally do Sunday night. So feel free to pop into one or more of our sessions next week. And we look forward to seeing you again. Stay healthy and safe, everyone. Be well.
Thank you. Bye-bye.